Thank you very much for inviting me to talk on the topic of a real-time prostate cancer radiation oncology research database, which is quite a mouthful. My name is Thilo Schuler. I'm a first-year trainee at the Northern Sydney Cancer Centre, and I have a background in health IT. I have a master's and have previously worked in health IT as well, both in Switzerland and in Australia. I'm talking today on behalf of this group, which is led by Associate Professor Thomas Eade. Before I start with the fairly dry topic of databases, I want to share this cartoon with you, which I liked, which demonstrates what happens if you don't have enough data. We all know that clinical audit and research requires high-quality information. And we also know that electronic medical records can contribute to effectiveness and efficiency of collecting high-quality information. However, the current systems are often inadequate to do so. In our center, we're using ARIA, and we found that to collect research data in routine care, ARIA wasn't customizable enough to achieve that. So this table contrasts the perfect world and the common reality of data collection for research. While ideally data should be correct, complete, electronic, and structured, data quality in reality is often impaired by issues such as doctors skipping fields or usage of paper records. So in order to generate high quality information for research purposes, we felt that research data should be collected at the point of care. And so in 2007, we implemented a real-time prostate cancer research database. This database collects clinical and pathological information. And in order to be practical for routine care, it had to be customized for and continuously adapted to the clinician's needs. And we achieved that by developing the database in-house in an iterative process and based on continuous feedback from clinicians. And such a process is also often referred to as agile development. We selected MS Access as the tool because we already had in-house knowledge with MS Access, and the rapid application development nature of MS Access made iterations faster, which was beneficial. These two screenshots here give you a sense of our solution. The top screenshot shows the follow-up screen with, in the top section, information about the patient's cancer and the treatments so far. And this part is usually, the data in this part is usually collected in previous visits. And then in the bottom section, there is data entry fields that are filled out during each follow-up visit. The screenshot there on the bottom shows the biopsy form, where we collect information such as core positivity by prostate region, and the different regions are represented in this prostate-shaped form there. We analyzed the usage of our database, and to this date we have more than 1,600 patients in the database. Of these patients, 78% received radiotherapy at our center. And of these patients that received radiotherapy, 90% had at least one follow-up entry, and 36% of patients had more than 24 months of follow-up data. The information in our database contributed to 5 formal clinical audits and 26 peer-reviewed publications. So overall, this shows that our database is contributing to high quality information for research purposes. Our experience shows that a real-time prostate database is feasible. This is also reflected in the fact that we have established this real-time database model for several other tumor streams in our center. And we identified the following success factors: clinician-driven design, agile development, and senior clinician buy-in. I would like to use the recent arrival of PSMA scans as an example of how of clinician-driven design and agile development. This new prostate-specific PET scan has changed prostate cancer practice in our center in the last year, and we were able, within a few iterations, to integrate this new practice and the data requirements into our new database, and it's been in use for over half a year now. On the next slide, I'll provide an example how senior clinician buy-in is important to increase data completeness. And this is an issue that Graham also noticed in the previous talk. So this diagram shows follow-up completeness reflected in the gap between the blue and the red bars. And in the first 3 years, about 50% of our patients had follow-up data. Then between 2010 and 2012, this increased to about 2/3. And from 2013 on, almost all the patients had follow-up data. We achieved this by getting senior clinician buy-in. Once the senior clinicians endorsed and enforced in a way the usage of the database, the data improved. So this is not just a technological issue, but also a change management social problem that needs to be addressed. These are the key limitations that we have identified, and most of them relate to the use of MS Access. There are limited user interface possibilities in MS Access, and that sometimes led to clunky data entry solutions. Due to limited error handling possibilities in certain situations, sometimes annoying freezes and shutdowns can happen. We found that accessibility to this database from outside the organization is difficult. And this particularly became evident when consultants started to treat patients in St. Leonard's and Gosford. Our solution is not truly multi-user capable. When 2 users try to write to the same patient at the same time, this can lead to data loss, which is clearly a problem. And our solution currently is not integrated with any other systems, and that can lead to avoidable manual labelsome data entry. And there were some issues with very large tables in terms of how many columns. So at the moment, we have a next generation real-time radiation oncology database project underway at the Northern Sydney Cancer Centre. And hopefully we can present next year at this conference about this project. So in summary, our experience shows that real-time research databases are feasible if driven by local clinicians who participate in an agile development and provide senior clinician buy-in. Our current system has limitations which are mainly related to MS Access, and a next generation system is being developed at our center at the moment. Thank you very much.
Thank you. I was wondering if there's any questions from the audience for this presentation. No?
next project dealing with the lack of integration problem?
So we're trying to, taking ARIA as an example, we're trying to use existing interfaces. For example, there is an interface to import by programmatic means documents into ARIA, our plan is to create extracts from our current, for example, from a follow-up visit, and create a document that gets automatically imported into ARIA. So that allows us to not have to go to several systems during one small consultation, because at the moment some of the incomplete data stems from certain clinicians only using ARIA at a certain visit and vice versa.
That's great, thank you. I'm afraid we have to move on, but thank you, Thilo Schuler, for your very, very interesting presentation. Thank you very much.
Just